Hey, welcome to the Russ Show, where we explore ways to get healthy, wealthy, and wise. With a combination of guest interviews and solo episodes, I hope you will be inspired and motivated to become the best of whatever you are. I'm Elle Russ, #1 best-selling author and subject expert with over a decade of helping thousands of people across the globe. Visit my website, elleruss.com, to learn more about free guides, masterclasses, online courses, and more. Enjoy the show. All right, everyone. Today I have Dr. Gary Foresman with me of middlepathmedicine.com. He's also the doctor on my book, The Paleo Thyroid Solution, and my doctor. And even though he's not taking new patients, he has a wonderful PA named Abby who he has trained. So if you need someone to do telemedicine for you in the United States, go to middlepathmedicine.com. I'm going to start off. We're going to go through a few thyroid topics today. I'm going to briefly just share with you what's happening with this NDT ban. So as of August 18th, today, when this is being recorded, the ban is not rescinded, but there are a lot of accounts online, very large accounts, some with 1 million people, that misinterpreted some tweet from someone, and they're going around going, hey, it worked. You know, they heard us. The FDA ban is gone. That's not true. But let me just give you in layman's terms what happened with this. So basically, back in 2022, the FDA changed the rules and said that natural desiccated thyroid is now considered a biologic drug, meaning it's coming from animals. And that means that they have to file for something called the Biologics License Application in order to stay on the market. They call that a BLA. So originally, in 2022, the FDA gave these companies, Armor Thyroid, NP, Nature Thyroid, it gave them until 2029 to comply and get that done, which would have been plenty of time for trials, paperwork, approvals, etc. But at the beginning of August, the FDA suddenly cut that deadline by 3 years. They moved it up to August 2026, which only gives everyone a year to transition. And that's a huge shift that leaves these companies scrambling. So here's the bottom line. It's not banned today, but if nothing changes, it could be forced off the market in 1 year instead of 4. So what we're asking, the Thyroid Alliance, composed of me, other thyroid experts, and people like Dr. Foresman jump on there as well, we're just asking to keep that original 2029 deadline so that the patients don't lose access while their companies do the work to comply. So it is still available, should be for a year, you can transition to synthetic. We hope you don't have to, but that's where it stands now. So, Gary, that's where you come in. I just want you to geek out a little bit, but make it middle school talk for everyone so they can understand why. It seemed as though NDT was grandfathered in under the FDA, and it's been around for 100 years. So what's this change, or give us a little bit more juice on it than I can give, because I'm a dum-dums.
That's hardly true, but
the
I'll
geek
roll
stuff
with it. So, yeah. But if you pointed out, I can't remember, it was one of your podcasts, it's been around since like 1892, basically. Using desiccated thyroid originally was done subcutaneously, moved into oral tablets. So we've been using NDT for, 100 plus years as far as that goes. So why now the urgency to take it off the market? And this goes with other, I think, just to put everybody into perspective, this is why it's so difficult for us this kind of movement to do your own research. Can you trust the organizations that make recommendations? And this goes back to statin therapies and a whole bunch of other things, not just this thyroid stuff. The American Thyroid Association and endocrinological associations are controlled by big pharma, by money-based interests, and that's just the truth of things. And the recommendations that come from these organizations are not about patient care. They're not about how to take care of people. They're about how to take care of companies. Okay. And so, it just gives you the background for this. This goes into the broader spectrum issues of, healthcare, capitalism, the whole spectrum. How do we protect people and not just corporate profits? Okay. And, so how does all of a sudden it become an emergency, something that's been used for, again, 130 years or so, to just say, gosh, it's not safe now. We've got to take it off the market. And you already gave the background as far as this goes. From it was especially in the 1970s that doctors when the TSH became more available, they were going to dose and treat to the TSH. Okay. And you can get a more reliable adjustment of the TSH, which is thyroid stimulating hormone, everybody. That's the pituitary talking to the thyroid, with using just a T4 only prescription. And it became the standard of care because it was easy, not because it was the right thing.
Right.
And and so T4 became this standard drug. And of course, then big pharma, the Synthroids, Levoxyls of the world, started advertising to doctors. I've been to these, pharmaceutical-based lunches and dinners. By the way, it's really kind of hilarious in terms of the money they have to promote this use of the TSH as the only test that's out there. And this has really been going on throughout my entire career because it was happening right about the time that I became a physician in the 80s. And so we weren't really taught to use desiccated thyroid, even in the 80s, by the way. And you didn't learn about it until afterwards, and you started looking at what other doctors had written, the Broda Barneses of the world, et cetera, and how other physicians looked at thyroid and the lack of reliability of the test, not just this TSH. I promise we'll come back to this, but this takes us directly to what's happening with NDT, is that it became part of this, the integrative medicine, complementary medicine therapies, when doctors would actually listen to their patients and listen to their symptoms, treat with things when T4 didn't work alone on its own, and the TSH was understood just to be one other test. It was not, I think it was Shaughnessy, they kept on repeating, in Thyroid Power, the tyranny of the test, which is, do you just use TSH as the only marker for thyroid function and no longer listen to your patient? And that's what the average doctor is being taught right now.
Yep.
You do not listen to your patient. Okay. They don't matter. That all that matters.
I'm like been there, done that 1,000 times. Like,
exactly. And I wish I could tell you this, it's like, that's when I always joke about being an MD and almost being ashamed of it, is the organization. I'm not kidding. It's
no, I get it. I get it.
Organizations that supposedly represent my viewpoint really make the actual person, the individual. And we all know about biochemical individuality, by the way, and not treating to a mean, meaning an average TSH or an average T4. You're supposed to treat people. I know it's weird and everything, but so it became this movement to push people towards T4 only, and you've been through it, and so many of our patients that are listening today have been through this before. But what happened, and you and I know, back when we did the book, that was like Nature Thyroid was my primary desiccated thyroid that I used when people weren't doing well on T4. Even at that time, I'd say more than ever, I would say, let's start with T4. You can use generic. It's covered by your pharmacist, your insurance, and let's see if it works. And there's nothing wrong with that, by the way, for doctors who do that to start. Okay, and listen to them clinically, not just to the TSH. And so.
I want to interject, though, and say that before you had mentioned in our book that you prefer and don't prescribe levothyroxine generic, if that would be your choice. Does that? And other thyroid experts I've talked to have said the same thing, where they don't like to use generic levothyroxine. Do you still have that viewpoint?
I still use that standpoint. Of course, I have some patients who still complain about the cost of a brand name.
Gotcha. So you'll do it. You'll give it to them with warning, but you'll say
with warning. But I do prefer. I'll use say Synthroid DAW1, which is prescription. It means just dispenses written. Sorry, everybody. And just head them towards GoodRx into websites so they could bring the cost down, because, as you know, the potency of a generic levothyroxine and a brand name Synthroid, I'll use the most common brand name, are supposed to be the same. Okay, within 5%, of the potency of the 100%, so 95 to 105% of what's written on the label. It's just the bioequivalency, meaning the excipients and other things that are present within the tablet can vary, especially among the generics. So the problem with you get generic levothyroxine, everybody, is you can go to a pharmacy and get a different generic. I wouldn't say every time, but it can happen frequently enough, and it's happened to my patients, where one generic acts differently in their body than another generic.
I've felt that experience with certain generic T3s.
And that has to do with the bioequivalency, more to do with the excipients, because theoretically that prescription should be within 95 to 105% of the listed, 88 micrograms or whatever you're taking of T4. And so the problem you get with the generic is you can, if if you do get a generic, make sure you get this, and you're doing well with it, get it, make sure you get the same distributor every time from whatever pharmacy you're getting it from.
Right.
Okay, that takes away some of this, this variability that occurs with all the different generics. And so that's where the problem comes in with the generic T4. So on average, to stay consistent, you would like to do with one brand name and say, this is the one you're going to stick with. So we know that we can try to find a consistent dosage with for you without the variability of the bioequivalence problems related to the excipients present in different generics. Does that make sense?
It totally makes sense. And how do you feel about T3 generic? Is it the same
It's the same kind of
spiel?
problem.
Okay, well then, shit, maybe I'll switch to Cytomel.
So if you use Cytomel, but if you can try to find the same T3 generic, you just want to make sure the pharmacy, is this the same one I got last time? It's the same problem with doctors, by the way, for everybody, is the pharmacist today they're more, the average pharmacist is more of a dispensing machine. They don't compound, they just dispense things that come from the pharmaceutical companies. So they're really dispensists more so than pharmacists. And what they dispense you, do they really want to look up whether you're on the same generic? No, because they don't feel like they have the time. They're overwhelmed and understaffed and all these other things. So it becomes a little bit of a problem with your pharmacy, depending on the pharmacist, of course. Okay. And so, but if you can get the same generic that you get consistently year after year, then it should take away that problem with the variability between the different generic pharmacies.
Got it. Okay.
Including T3.
All right, great. I want to move on to this topic. We've talked about it before. So, for example, there are lots of endocrinologists usually cap out at, we won't give a patient more than 5 or 10 micrograms of T3. And that wouldn't work for a ton of your patients, right? They'd still be hypothyroid, including myself. Now, I am not on a high dose of T3, but I want to take CJ Hunt for an example, and he's talked about it publicly with me, so I can mention it here. He's 70 years old. He's the director of the Perfect Human Diet, the Ancestral documentary. If you haven't seen it, it's great. And he dropped dead basically of like a heart attack, a heart event at the age of 21. And then he went searching for the perfect human diet, and that's how he did what he did. Well, years later, he had to go on thyroid hormone replacement, and the T4 backfired on him, and everything backfired on him. And long story short, he has to be on 175 micrograms a day, which would kill me. I would be in the emergency room with a heart attack, without a doubt. But here's the thing. Can you please tell us, and I love your analogy of, we can test the keys, not the locks, and also why nobody should put caps. I feel like the answer from every doctor should be, we do what's right for the patient. We don't put arbitrary limits on anything because it's so different. So can you just kind of, tell us or give us a few examples if you have anyone on a high dose of T3, just because it's just so arbitrary that like some clinic would say, we're not giving more than 30 micrograms when the patient needs 50.
Right. It's yeah, it goes into the problem of standardized medicine. Okay, especially when HMOs became out there and the doctor was encouraged to have shorter and shorter visits, spend less and less time with you, and treating to a biochemical number is easier than treating a person because the person talks and they're annoying. Sorry. And the numbers, let's say if you just use a number. So when it comes right down to it is that on some average person that used to be the 70 kilogram male, right? 154 pounds. How many 70 kilogram males are the standard anymore anyways? And so, and even though all throughout our literature, we know that biochemical individuality exists, treating to a biological mean, a bell curve distribution, makes even no sense whatsoever. It's what the average doctor does, probably because of time constraints, probably because of insurance constraints. And I'm not just justifying what they do, but there are reasons that push this way. And I want to be clear too. The average doctor has been each generation that I see is becoming more and more, and I can be kinder, but more and more stupid about the testing because they're encouraged. They're actually flat out told that you don't measure T3, you don't measure reverse T3 because, integrative doctors do that. Barely can you get even a T4 level out of these people, okay? Mm-hmm. And that's a standard doctor because they're being taught to do this because anything that will take you away from standard of care, okay, is being squashed. Okay. We've done this before when we talked about statins. When I recommended this thing called a coronary calcium score,
Yep.
why was it not covered by insurance? It's been around for over 40 years, people, because statin drugs can treat heart disease. You're not supposed to treat cholesterol. That's a whole nother subject.
Yeah,
So,
by the way,
uh,
we've done a podcast on
uh,
that, and I might even
and
re-release that. It's good.
and
Yep.
the reason insurance won't cover it is because it might take you away from taking statins, which are the standard of care, and you're supposed to treat to a certain cholesterol number. Everything about that policy is wrong, with a little glimmers of truth that statins can have a role in treating heart disease. Okay. So the same thing is coming back to what's happening with thyroid. Why are doctors being made into these pre-programmed automatons who don't seem to understand these tests? It's because they're literally discouraged. I think we joked a while back about when I did CME for thyroid. It was so disappointing because it discourages the doctor from ordering any tests. Okay. And
Well, if you don't test it, it's not a problem, right? Didn't you say that?
that's exactly it. Okay. So how do you know if there's a free T3 as issue? Well, I just won't test it and it won't be an issue. Or are there reverse T3, etc. And there's so much, especially reverse T3. If you say reverse T3 around an
They have a
endocrinologist,
meltdown.
they might actually have the heart attack that you would get on the 175 of Synthroid. the because that's just a fun thing to do. Watch the little temporal arteries pop out if you say RT3 around an endocrinologist. And let me just I love to riff, and you can cut this back down. But if you look at the research on reverse T3, it's everything, even from Frontiers of Endocrinology, etc. I'm going to put a whole bunch of articles on this eventually. It's just I have a whole bunch of backlog of things to do. But their concern was if you ordered the reverse T3, you might overdose Synthroid. Just the opposite occurs. By the way, when you see that the reverse T3 is going up and up and up on a T4 prescription, it correlates directly with the patient's symptoms and directly with the reason why you would lose less T4 and more T3. So
I've seen too many clients coming in, and they have a reverse T3 problem because the doctor keeps throwing them T4 and doesn't understand to test it, making them more hypothyroid. It's mean. It's dangerous.
You see it all the time, because I see so many thyroid patients, and myself and Abby as far as that goes, and so it's just strange how internal medicine doctors, everybody, are supposed to be like the ones who like digging in, and there's no tests we don't love. So it would be so horrible to be a physician of any kind, family practice, internal medicine, of course, endocrinologist, and order fewer tests. It would just be horrible.
Right.
I mean, why? It's all the fun, and don't get me wrong. You can get caught up in the tyranny of the test and just, start treating laboratory numbers and not people. But as getting some objectively true data, because when you read through the books from like 70s and Broda Barnes to, onward and upwards, what I would tell you is they didn't have good testing back there. But, the ultrasensitive TSH, along with free T4s and free T3s, which even, well, I can't remember when Shamus's book, Thyroid Power, came out. I think it was like 2010 or something like that. But they didn't know much about it. So it's evolved. Each decade, we have better tests. Okay. So, and as we get better and better testing, the doctor is encouraged to do fewer and fewer tests. Isn't that weird? Okay.
Yeah.
Because that testing would actually tell us what to do along with your symptoms. Don't get me wrong. I'm not saying, because I have some patients who have low free T3s, sometimes, okay, or even somewhat high reverse T3s, and you ask them, they have no thyroid symptom. I mean, and they feel great. They have more energy. I'm 85 and I'm bouncing off the walls and I'm doing great. I have poop perfect, etc. skin.
You got to listen to that too.
And you go, wow, your labs don't look like that, but if you're feeling that good, I'm not going to mess with you, because that's the other side of it. If the person's feeling badly, let's quote unquote mess with you.
Well, actually, the other side of it is something that happened to someone in the industry, no thyroid problems, no history of thyroid problems, fit, doing great. But their free T3 was a little bit below the mid-range, but they felt fine. Had, again, very T3 efficient athlete, right? So it makes sense. Right. But someone saw this and said, oh, no, we need to give you thyroid hormones to get it to the top of the range because that's optimal. And you're like, no. That person is totally confusing a hypothyroid patient being optimized and what maybe that lab could look like versus just a normal person. And they called me and I said, don't you dare go on thyroid hormone replacement. Not at all. Who is this outfit you're talking to? What are they doing? So I've seen it the other way too.
And it goes right to what you're talking about, the the efficiencies of the different deiodinases in terms of how they work within the pituitary versus other tissues, etc. And this takes us
By the way,
directly.
just let's break in there. The D1, D2 are enzymes that help with conversion from T4 to T3. So that's what he's talking about.
Correct. And so, and so there are variations genetically I'm talking about for everybody for
Mm-hmm.
in terms of all those types of things, and we get back into the effects of toxicants in our body, meaning
Mm-hmm.
things that aren't from the roundups and everywhere else in the world, affecting the transport of T3 from the nucleus to the nuclear receptor to the actual DNA itself, turning things on. There's a lot of proof that there in our toxic world we're not able to measure this thing with T3 conversion. We are within intracellularly, by the way. Even our blood tests don't do that. Okay, so that's why we have to treat clinically, because it's very interesting. Like a patient of mine said, well, the desiccated thyroid is so wrong because it's 4.2 to 1, T4 to T3, whereas the human does it 15 to 1, which is, by the way, out there in the world and is actually completely wrong. Because if you look at the real studies in humans, it's probably closer 8 to 1 T4 to T3 compared to porcine thyroid, which is 4.2 to 1. But when you look at TSH thyroid, TSH stimulation test, TRH stimulation test, that it probably is very close to 4.2 to 1, very like the pork thyroid in terms of how our body actually likes to get thyroid out to you. So when TSH goes up, gets your thyroid to make more thyroid. That ratio of T4 to T3 is very, very similar to the porcine thyroid. And that's the exact opposite of what every doctor's in every textbook. It's 15 to 1, 15 to 1, and it's wrong.
Mm-hmm.
And so whether it's 15 to 1 or 11 to 1 or 8 to 1 or closer, I'm just going to tell you, porcine thyroid very much mimics what we do, what our body would make
Okay.
on its own if it was working. Okay. And that's
Um,
another common misconception for the endocrinologist and everybody else. You can't use that T4, T3 product because it's so different than human, because we rely on T4, T3 conversion at the level of the, each cell doing it on its own, which is partially true, of course. But we can't measure that. Okay. So
right.
if we can't measure that and T3 might not be so reliable, let's just not measure it, is kind of the standard. And it takes us to the point of your question, which is, and when we have, doctors just measuring only TSH maybe reflexing to a T4, they're missing the most valuable active thyroid hormone, free T3. And even though that's not a perfect test, because we don't know about peripheral conversion based upon just blood tests, okay,
Mm-hmm.
and we don't have the reverse T3 because the doctor won't order it. By the way, we can't order that, and they change throughout the day. So when as you take your thyroid in the morning before you do your thyroid test, you'll have different thyroid functions than if you hadn't when you take NDT, of course. And so
And let's
um,
tell everyone, when you're taking a T4 T3 combination or T3 only, anything with T3 in it, you do not take your medication before the test. You wake up, you get tested within 2 to 3 hours after waking up. And can you explain? I mean, we talked about this in our book, that the free T3 and free T4 are what's free, unbound, and available, not what you just send spiking through your system. I did an experiment years ago. I told you I was doing it, and we talked about it. I took a test in the morning without taking my thyroid hormone. I went back to the lab, had them prick my other arm 2.5 hours later to see what the result would be when my T3 was spiking. Now, that result would have looked like any endocrinologist would have jumped out of the window and been like, you're hyperthyroid. But we had this conversation. You're like, well, that's when it's peaking. You never
right.
tested then. But it was such a difference between what was free and available and what was peaking, right? I didn't feel nothing felt different. Anyway, back
So
to
everybody,
not getting tested
when you
before.
take T4 only, after about 2 weeks, there is no dose to dose variability in your blood test. Your body gets to a steady state and you're just
Right.
maintaining a steady state. That's why it doesn't matter when you take
Matter as much.
T4 only. It doesn't matter when you do your lab test because it really doesn't change. Okay.
Right.
And so whereas when you take a T4 T3 combination of any kind, T4 T3 separately, NDT, etc., then you really do want to. You can measure peak levels if you wish to, okay? But be very clear. If you have a pretty good dose of T3 and you do your test like 2 hours after your T3, your endocrinologist, your thyroid doctor will
Yep.
freak out, okay?
Yep.
Because
They would have
the
freaked out if
reference
they saw that.
range is based upon not people who don't take T3. And this is why we used to call them star doctors. If there's a star next to it, they freak out, or it's colored blue or H or L or whatever else like that. So the doctor, again, and I know it seems like I'm tough on the average doctor, but they seem to have no ability to interpret tests based upon their own research. Their understanding reference ranges are so inaccurate on almost everything that we use. Okay. And, and they don't measure the free hormone, which is the biologically active, unbound. That's what a free hormone is, not bound to the thyroid binding globulins, to the albumins and other things. So that's why, measuring free hormone, by the way, everybody, you have to do the same thing with your male patients on testosterone, etc. You have to measure free hormones to see if you're actually low testosterone or not. But that's what goes on and on. So free hormone is an advance in testing because you're measuring picogram levels sometimes, super low levels, of hormone, but radio immunoassays, etc. The way we do things now, we can find that. So that's why the tools of today are better. Even with a book written in 1978, even from the book written in 2010 or whatever it is, and even as we do a book 10 years from now, we might have better even testing further.
But can you get into and explain why someone like for example, my friend CJ who's takes the crap load of T3, but if you looked at his actual tests, the free T3 is not that high. I mean, it's not. It's not. It actually, for him, it's a normal, but he has to take so much to get there. Can you explain that locks, keys thing and what?
Variability of absorption, variability of metabolism. That's why there's no set number.
Right.
And just very briefly, some people, oh my gosh, you can't take more than 2,000 units of vitamin D. That is so completely wrong. You measure the level. Some people need 10,000 units to get a level in the bloodstream, which is what you can say. Hey, we don't have to believe in vitamin D. We can measure it. We don't have to believe in our thyroid hormone. We can measure it. I'm a big belief is wonderful for intangibles, but these are measurables. Okay. So you just measure it. So and going into the T3 concerns that the endocrinologist, and I've addressed this in other T3 articles I've written, by the way, but the mythology of osteoporosis, T3 does not cause osteoporosis. And this is really important, everybody, even if your TSH is suppressed, because you can measure a bone breakdown marker when you do up your dosage of T3 called urinary N-telepeptide and by the way, almost always when you improve thyroid hormone metabolism, the N-telepeptide, the bone breakdown, improves because optimized thyroid is good for your bones. Okay. So you don't have to just believe because your TSH is suppressed. Oh my gosh, I've heard that's bad for your bones. It's been proven repeatedly that that's not true. But
right, and let's do a rundown real quick, because in my book, and we've talked about this elsewhere, but we might as well for the people new. Here's the thing: back in the day when Gary was in medical school, how many decades ago? No offense.
It really was. It's almost frightening.
It's almost frightening. But when you were
I'm the age of the doctors that when I came out of medical school, I said, "Don't listen to a doctor that old. They don't know shit."
Right. Okay, so here's the thing. You told us about this. Back in the day when people had thyroid nodules and everyone was uninformed about this, what they did is they did this protocol where they jammed a patient with a bunch of T4 to try to reduce the nodules. And while it reduced the nodules, it made them, quote, hyperthyroid because it suppressed their TSH. And you never want to suppress a TSH on T4 only, because now you're looking at. And so what happens is they saw arrhythmias and bone issues and then that false fear. So just give us a little rundown on that again, because there's still doctors out there. I mean, everywhere, every day I get something from somebody about they're scared that my TSH is suppressed. On T4, T3, we want to let everyone know this discussion right here, not applicable to T4 only users.
Exactly, because the concern about the suppressed TSH is when we use T4 only, and you never want to suppress TSH using T4 only unless you're having, excuse me, I shouldn't say never. There's always a case. People who've had a thyroid cancer history, they do that when they're trying to keep the TSH down, because at least for 10 years afterwards, you want to make sure the TSH is suppressed, okay, to make sure that's one way of preventing thyroid cancer recurrence. Anyways, so in the general population, this is not what you do with T4. But, I would tell you is that first, I want everybody to listen. There's this idea that you can only listen to doctors about this, but the doctors are indoctrinated. Okay. What Elle just said there is so wise, because she knows that the studies show that that's just T4, that those studies causing the suppression of TSH are an issue, and that they don't apply, because we know with T3, what's called the area under the curve, you get a higher peak Okay, that higher peak of T3, when you take any form of T3, NDT or simple T3 or a sustained release T3 from your compounding pharmacy, will cause a greater suppression of TSH than T4 does. Okay, so
Right. And let me
even at
just
the
explain
right
that to everybody.
dosage,
Let me
okay, so
just kind
even
of
at the right dosage, it will do that. Yes,
Yeah, so the brief one, and I mean everyone, hopefully you guys know this, but the TSH is sort of like your sensor, and when your body gets low in thyroid hormones, it will shoot out a signal to wake up call to the thyroid. Well, that wake up call gets shut down because you already gave it to yourself and it sees it in your blood. So it's like, oh, well, we'll shut up. They got it. We don't need to wake them up right now. That's
correct.
why the TSH is usually suppressed when you're on a substantial T4 T3 combo or T3 only, right? So
Yeah,
it's just such a it's still it's still hurting patients, right?
it is.
Off of
And
this stupid protocol no one does anymore.
right, and just to give you guys an example too, the TSH, so many of the books out there, and this goes back to treating tests and not people. If your TSH is 6, oh my God, you're hypothyroid. We have to put you on thyroid. What are your symptoms? How are you feeling?
Yep.
Some of my healthiest thyroid patients, I followed them for like 20, 30 years at this point, and they'll have TSHs that go 3, 6, 5, whatever. They seem to have this really, and they have some of the best thyroid functions around. I'm talking about actual thyroid functions, everybody, which means free T4, free T3, and reverse T3, and they have no symptoms. They seem to have this elegant conversation going on between their pituitary and their thyroid, kind of more share like and moonstruck, snap out of it. It's the TSH, the pituitary, boof, I need to hit you a little bit, and it goes up a little bit. We measure that, and it's just this ongoing conversation that must be just more dramatic than the average person. And you'll have people with TSHs, if you just don't treat them, okay, meaning you don't give them thyroid, because we can always suppress your TSH with some thyroid. I can't tell you how many people I've gotten slowly off of thyroid. Their TSH is up a little bit, but they have the best thyroid functions ever, and they feel wonderful.
And
Okay,
that's all that
so
matters,
so
really. If
and
you're feeling great, what's the problem?
so you don't have to treat a TSH just because it's above 2.5 or above 4 or whatever even the complementary doctor sometimes says, because that's not true either, because they're not treating people. Okay, once again, it's like we always say with nutrition, right? Nutrition treats people, not diseases. Okay, and the same thing goes when it comes to our thyroid hormone. We are trying to treat you as a person, not as a disease.
Mhm.
Okay, when you use the tyranny of the test, when you only use test, you're happen to then now you've become a disease that so happens to have a person, and that's what we're trying to avoid in any form of true medicine. Okay, integral medicine, integrative medicine, whatever we're trying to say here, because they're going to people with a TSH that's running a little high, that doesn't need any thyroid medicine at all. And if you just talk to them, you know that. Okay. And then there's some people who run a TSH that looks fine. Let's say it's 3. Okay. But, and by the way, almost always in my experience, you can tell by their free T3, free T4, and reverse T3, yeah, there's something going on here. And
Yeah.
their TSH isn't picking up on it, probably because of the unique pattern of D1, D2, deiodinases in the pituitary versus their peripheral tissues that somehow is interacting differently. The TSH isn't reliable in them. And I want to make sure you guys also hear this. In my career already, the many men with low testosterone have perfectly normal FSH, LH. These are 2 hormones that called follicle stimulating hormone, luteinizing hormone, that come from the pituitary, and they're supposed to talk to your testicles. And if your testosterone levels drop, they're supposed to just go up and up and up. It's like, oh my God, you need more testosterone. You never see it anymore. Okay, I shouldn't say never, almost never. You have profoundly low testosterone guys, okay, based upon their symptoms and their low testosterone, by the way. Shocking that we actually measure testosterone. And not just LH and FSH. Why aren't we just measuring pituitary hormones? The answer is because it's not reliable. I can't tell you all the reasons why, everybody, but anybody who uses the TSH only, which is what the American Endocrinological Association, the American Thyroid Association tells you to do, it's 100. It's well, I shouldn't say it's 100% wrong. It is absolutely an invalid way of
It's
approaching the person.
90%
Okay,
wrong because
it's
again, you
exactly
have to look at the other things to know what's going on. That is
correct.
just
And
well, and
and
also I was mistreated.
no,
My TSH was quote normal, right? But
right.
I had 0 free T3 and 0 free T4, but it was like within range, and of course they kept telling me no problem, right? I mean,
Correct.
it's just
Because the reference range includes unhealthy people. Okay.
yeah.
And let's be the same. Women, so many women are iron deficient. And I promise this makes because iron deficiency
Yep.
is such a huge problem, everybody. The reference range range in some labs for ferritin, which is your iron storage, is from 5 to 400. Okay. Now, 5 is profoundly deficient, but if you had a 6 and saw a standard doctor, they'd tell you have enough iron, and you don't. They've shown very conclusively, even if you're not anemic, which you probably are if it's 6, but
Right.
even if you weren't anemic, okay, that level of low iron affects sleep, so many psychiatric conditions. It goes on and on and on. And the reason the reference range includes 5 is because iron deficiency is so common that it became normal. Okay. Now,
Right.
flip side of things is your ferritin gets over 100, you're getting into iron overload. So if you had a 350 on your ferritin, like many men do, they are iron overloaded. They should go donate blood, which would be good for society anyways. And
And I
so
want to interject and say sometimes with a hypothyroid patient, even if they aren't overloaded on iron or aren't taking any iron, they could have a high ferritin, which could be masking the true ferritin and kind of denote inflammation.
high ferritin, very good. So you only interpret ferritin based upon healthy inflammation levels. So this has happened to me, and it actually still happens on occasion, I'll have to admit, where you think, oh, the ferritin looks fine, and you forget that they're so inflamed. You put them on a paleo diet, you get the grains out of their diet, you do everything else that you need to bring down inflammation. So you bring down this like wicked inflammation in your body, and you feel good, and then poof, all of a sudden, oh man, the ferritin's sitting at 10 now because we were being masked. The inflammation drove up the ferritin and made you not realize, oh, wait a minute, they really are iron deficient. So once you treat the inflammation, poof, they're iron deficient. And it's not a new thing. It kind of freaks you out a little bit. It's just because you've treated the inflammation. And
That's
that's
right.
the problem with any test. You have to be careful with how you interpret it.
There you
And
go.
so, but the reference ranges, including the T3 ranges, including so many other ranges, include unhealthy people. Okay.
Yeah.
And so that's really important. That's why we always talk about what is an optimal range for, say, a ferritin. What is an optimal range? And this is the problem with the T3s. People telling you your T3 has to be on the normal, on the high end of the range. That's just not true all of the time. It's true
Right.
some of the time. Okay. And so, so be very clear. It goes into this biochemical individuality. When I talk to my patients about the cholesterol profiles, hey, with this HDL, these are all great, but the tests are in the red because the average Western doctor, all they care about is LDL, and poof, they want to get you on a statin drug. The same thing is happening with our thyroid hormone, but that they're just treating to a level, not treating to a human. Okay.
Right. All right.
And
Let me ask one.
they're missing data points is the point. And they don't care because they're so busy and
Yeah.
seriously, they're so busy that they just don't have the time to care.
Yeah. Oh, it
Mhm.
sucks.
Yeah.
Out of curiosity, what is a current, like, if you know offhand, like what's roughly like the highest dose you've ever had anyone on, or like some patient that really needed a lot, right? Versus someone who could get optimized on a grain of NDT, which is rare, but that
Exactly.
happens.
I
What's the
have, I mean,
swing
such
upwards? Yeah.
Oh gosh, I mean, I know I have one lady who's taking right now 350 micrograms. She has to get a 300 and a 50,
Of
and
T3?
of T4. No, sorry, that's
Okay.
T4. Sorry, 350 micrograms of T4. How much is the most? Because again, when you split up dosages, so let's go back to this T3 thing. You can measure things that make sure you're not hurting your bones. So you and I can be reassured. And if you have an endocrinologist seeing you along with me, like God help me, but because it's that people ask me to talk to their endocrinologist. No, I've talked to that one already. It's like talking to somebody who
Right. Hit
doesn't want
yourself
to
up against a brick wall. Yeah.
exactly. Yeah, exactly. So, um, and then that's tachycardia. That's the other thing is can T3 with the fluctuations cause tachycardia? They've shown repeatedly that it can, especially if you get to the cytomel, sorry, is brand name T3, just the immediate release T3 forms. As you get to 25 micrograms, you're going to have an increase maybe up to 10 to 15 points in your heart rate. And most people are like, I don't know how good that is. Okay. So when you take T3, you usually split up the dosage as far as that goes. But I have people, oh, gosh, I mean, currently, I think the highest amount of T3 that I have people on are in somewhere in the 50 microgram range because most of the times, once they've been corrected, you can bring it back down again. So they may be higher for a while and then bring it back down again. They start to get tachycardic, by the way. So if they listen to themselves, by the way,
That's what happened to
average,
me, by the way. And I just want to say that. So at
oh,
first, I
there you go.
needed to be on a higher dose of T3.
Right.
But what you have to do, especially when you're coming off a reverse T3 problem, and I tell people this, I go, you really got to pay attention in the months that follow because
Yes.
things will change. And I noticed that it
Hmm.
became too much. I reduced, became too much. I reduced as my body was fixing itself, getting unreverse T3'd.
Right.
I needed less and less over time. I
Right.
mean, it's not always the case, but it is something that like you just, it's perfect what you just said. Sometimes people need a higher at first and then you
Mhm.
become
And
kind of,
then
yeah.
they start to realize, and it can be an irritability, it can be a tachycardia, palpitations, etc.
Hmm.
But something that just doesn't feel right. That's just why, like, I always joke that thyroid is not a drug of abuse. You don't when you
Yeah.
take too much, you don't feel good. Okay, so that's why don't we trust our patients with this? It's not like narcotics where they're just going to keep asking for more. It's like the opioid crisis. You're just going to keep on. There'll be black market T3. It's not like that. It's you don't feel good when you don't take the when you take too much of it. Okay, so people don't want to be on too much thyroid hormone T3 or otherwise because it doesn't feel good. So and so that's why
But there
by the
should
way,
be no one should cap it, right? There's
no,
no
there's
arbitrary
absolutely
anything. Like
no
you said, you've got a
arbitrary number.
huge dose of
Right.
T4 that would probably send a lot of
Right.
people into a reverse T3 coma.
Absolutely. That's why you have to be very careful with the T4. I have some people who do great with T4. Their insurance covers it. They don't develop RT3 problems for some reason, and they feel well with it, meaning they go up
Hmm.
and they feel better, which is, remember, we're always supposed to treat the patient, right? And so, but that's very rare. I want to make sure everybody hears that. It's very rare that I just do T4 only because there's some really good converters out there. That's just what it
Right.
comes
But
down
it
to.
but it often fails people and you've
you
got to
know
be
so
aware.
but
Yeah.
then so you start them on the easiest prescription, okay, and by the way, if the patient will let me, I will prescribe a standard T4 but a synthroid, say DAW, keep it there just to take the variability out of it and then listen to them if that's what they want to do. In my Especially this current thing, why are they taking the thyroid up? By the way, this is just capitalism 101. I'm guessing they made it faster because some drug manufacturer has already got their BLA already set up so that they'll take it off the market, and what could be a super inexpensive prescription will now become brand named as well.
Hmm.
And they already have this ready to go, and they will be the only one that holds the patent for the next 17 years on a desiccated
Right.
thyroid. Something that's been around for 100 and some years will now become like, oh no, it's a new drug. And it'll be charged
Right.
wicked money so that it becomes a high profit drug, which is once again why we have to be careful in a world with the only thing that matters is money. That's what that I can almost guarantee you that something like that is going on in the background.
Sure.
Why was there an urgency now? Elle, you've already pointed out to all of us felt upset when it happened to MP. It happened to Nature Thread, where their manufacturing glitches seem to prove exactly what the standard endocrinologist was telling everybody
Yeah.
is
It
that
proved the propaganda
it
kind of,
proved the
which is still
propaganda, which is like
propaganda, but it kind of
it's
proved it. Yeah.
it did, and it just chapped our behinds. But we said, all right, but they got caught. This, by the way, getting caught proves the USB system works. By the way, um,
Well, and by
so
the way, just for everyone to know, there we're talking about over the past 7 years, there's been mishaps manufacturing with several of these NDT companies where they put too much T3 or not enough, and it screwed up
right,
patients, and that
right,
sucks, and that didn't help us because that old propaganda of it being unstable,
right,
which it usually isn't, just
right.
didn't not a good look,
Right.
not what we
And
needed, right?
and it
So that
wasn't
was
unstable, everybody. It was just formulated wrong. So there was
that's
too
right,
much T3. It was
that's right.
like everybody was getting too much, say, T3. I can't remember the exact what was the problem, but I
Yes.
think it was too much T3. And but it was consistently too much. Sorry. And and so I would just tell you, even when they took off, like Nature Throid was my biggie, all my patients had been on the right dosage based upon how they felt in lab testing. It wasn't really a problem. Okay. It was just whatever was happening, they didn't do the right,
Hmm.
quality assurance, and poof, they got caught, which again just sucks everybody.
Yeah.
So that's this thing that, the issues that have occurred with MDT has promoted this idea that we can take it off the market because it's quote unquote unsafe. It is not unsafe.
Yeah.
It's a vital tool that we can use. And by the way, if it does go through, be reassured. We can try to find a dose of T4 and T3 taken separately that we can get to you if it does go through. In the meanwhile, I already had, as you can imagine, already had patients freaking out about this. But
Of course, that
and
every
so
day I'm getting.
yeah. So, and I said, listen, it's not, the ban isn't not till August of next year. So let's keep going on what we are. We're not trying to make changes because it took so long to get you to this position. I
Right.
don't want to try to do it again. And that's partly my own laziness, but it's not really that. I just, we took a long time to get them to the right prescription. I
Yeah.
really don't want to have to change it because of some idiocy from the American Thyroid
FDA. Yeah.
Association and FDA and whatever else. Whoever's pulling the strings behind this, by the way,
Yeah.
it's not
By
to
the way,
protect
I want
you.
to share with everyone because I was optimized on NDT many years ago and it saved my life. I will always be indebted to Natural Desiccated Thyroid as a form. I mean, I feel very indebted to Armor Thyroid. It saved my life. However, I am also here to say that I prefer synthetic. I feel better optimized on synthetic T4 and T3 than I ever did on NDT. And so I don't want people to be scared. There's a way. Now, I want to throw out one thing. We talked about this in the Q&A in the back of my book.
Mhm.
Where we talked about, I asked you, I said, hey, because, in NDT, you've got not only T4 and T3, but you have T1, T2, and calcitonin. I asked you then, hey, is there any evidence to say that, like, this is necessary? Because there are NDT propagandists who are like, it's better because it's got all of these things in it and it's got all the things you need and it's better. But you said that there was no evidence showing that those things were. So,
And there
uh,
still isn't. I mean,
okay, that's
the
why I just wanted
analogy
to.
the analogy that's given out there is this, like, instead of using artificial fertilizers, you want to use compost, right? And the idea, and that does sound great. He's just compared my NDT to
Poop
compost.
reference, yeah.
But why not have a good poop reference, And so, but the theory goes that those components might make it more beneficial. It might, okay, but there is really no evidence, and I actually recently searched that again. But
Because there's
so
T2
every
supplements out there. Are those
right.
worthwhile? Have you seen any?
No,
Like,
I would
that's
not
what I
go
thought.
that way. There's T2, T1. I've had patients ask me for going to the compound pharmacy to get T2, T1. I said, it's just no, I'm not going to write for that because there's no proof that's useful, that's
Okay.
useful.
Yep.
And so because it might be, but we want to have some evidence that it is, and then I'd rather use NDT if that's what you're looking for. Okay, some
That's
some
right.
some degree of T2, T1. By the way, that's also called MIT and DIT, by the way, if you're ever looking it up. And so monoiodotyrosine, diiodotyrosine is T1 and T2. What role they play in the human body, we don't know for sure. They might play a role, okay, but they might not as well. They just might be degradation products as your body is detoxifying and getting rid of extra thyroid. Okay, that's all
Right.
what they
And
might
and
be.
one of the other points I wanted to make, which and everyone can go to lruss.com/NDT. You'll hear a 4-minute video of me explaining it if anyone's confused. You can send them also to this episode as well. I might even just put this episode up on the page and aside from just the podcast. But one of the things I mentioned was, hey, the people that got onto NDT and feel great and are optimized, then are scared of synthetic. But then I would just ask the question, were you ever optimized on it? Because most people that were on synthetic prior to NDT were only getting T4 only. They were misdosed. And then they found a practitioner who knew enough to go, hey, you need some T3. Here's NDT. They felt better. And now they're like, synthetic sucks. And I would just go, but look, take a look, and I'm not saying there's some people that were on the exact dose of synthetic and feel better on the exact dose of NDT, but you know what I'm saying? There's that element. I just want everyone on NDT, just take a look back. Were you ever even optimized on synthetic? Or are you bad mouthing it or feel it's bad for you because you just had a bad experience with a bad doser? You know what I mean?
Correct. And so, and was it the variations that we were talking about by using generics, right? And
Right.
so, so there's a whole, wide array of those types of things that can, that could have been at play. And, and yes, I would just, because I'm going to have, I'm sure you get people that you coach as well, and then that they're just afraid to do this because they finally feel
Yes.
good on something. And you don't want to be forced into using something because of something really, really malevolent, which is what this is.
Mm-hmm.
And so, why is the FDA is not acting in your behalf? And by the way, everybody, this is proof that the FDA doesn't just work on your behalf. So just needing something to be FDA approved doesn't mean anything in the world. Okay,
That's
so
right.
and as we talked about, the organizations that make these recommendations really aren't there to help you. It doesn't mean that you can't trust science. What happens is science has been co-opted. There's a great book by was one of the PBS authors, but it's called Rigor Mortis, How Scientific Rigor Has Died. Okay. I
Mm,
recommend it to everybody. The rigor mortis is basically because if it's publish or perish in the university or world. And that means is that if you have to find something new, reproducing things, meaning the results from other universities or wherever the study is being done, there's no money in it. So nobody's doing it anymore. And there's been so much variability, even in the most basic biochemical research, that what is shown is that scientific rigor is basically dead right now because the money influence on publishing, on how you get published, is to find things that are new, not on confirming things. Okay, which is how
right.
science is done. You have a theory, you do a test, you get results, and you get reproducibility. It's called the scientific method. That is rock. That is great, and it has limitations in terms of complex organisms like a human. But on basic science, it's great. Okay, but it's not occurring anymore, and this is the biggest thing for everybody to hear. I did a whole series of articles on this, looking even at the antidepressant trials, and it showed that if a result wasn't showing positive for an antidepressant, what happens is they suppress it and it never gets published. Okay. So, and this is really important for everybody to hear. That means that we're not doing science anymore because everything should be published, including
Right.
negative results. Negative results don't get you into the New England Journal of Medicine or anything else like that, because the pharmaceutical company that doesn't want anybody to see that, it will get suppressed, probably never get published at all. Okay. And there's enough evidence that is true for almost every group of drugs, not just antidepressants, is that the negative results of from research are not being put out there. Okay. So that means we do not have the scientific method invoked out there. The more research you do, the more indoctrinated you are into what the pharmaceutical industry wants you to believe, because you can't find the studies that aren't published. Okay.
Right.
And
Right.
so, and then furthermore, like they're saying this lack of randomized, clinical trials on using NDT versus T4. There was a super trial, it was like about 12 years ago, I think it was, where they're looking at how patients prefer NDT it's 2.6 to 1 if they had a preference. The NDT versus T4, if you did it in a double-blind placebo-controlled trial, it was just 70 people. And they say, well, that's not enough people to really care, but it's one of the few pieces of evidence you actually have that people really actually do. Even if they can't quantify what exactly it is, they do prefer being on NDT versus being on T4 only if they have a preference. 2.5 to 1, 2.6 to 1 was the ratio. So, and then they say, well, there's not enough large randomized clinical trials. You know why that is? Is because they don't want to do large randomized clinical trials because it would butt up against the current,
That's right.
dogma.
It would,
That
like you
TSH
talked
is
about in
all
my
that
book, they're
matters.
doing the T4 study to prove T4 is the best thing at some university, and someone else comes in with another study, and that
Right.
company is going to pull their money out of the university
And
because they don't want something to contradict it.
so do we have an issue with research in today's world? Yes. And that doesn't mean just because this is the problem, because if we're shooting ourselves in our own in the foot, if people don't no longer believe in science at all, because that's not what I'm trying to get you guys to do. But you have to take a look at what you're reading and interpret it, understanding there might be research that you can't see that is just the opposite of that. Like I was saying, when you look at research for reverse T3, absolutely you'll get like this red flag from anything to do with the endocrinological societies saying not to use it, even though it's probably the most useful tool in my clinical practice.
Yep.
And what they're writing about it is the exact opposite of what I find in clinical practice. Okay.
Right.
So why is that? And the answer is because there is some subterfuge, something going on that is not science. Okay.
Yes. Yeah.
And that's the problem, is there's non-science, meaning profit-based medicine pushing an agenda, not science. And they use this, what is it? Colbert used to call it truthiness, it looks like truth, but it really isn't. There's something to it because it sounds sort of okay. And there's little glimmers of the truth in there. And so it makes it very difficult for you to do your own research. I want to make sure you hear about this, but this is one of my key points for all my patients. Stop looking outwards to see how you feel.
Right.
So don't but I looked on the internet and they said I should like have my T3 this. Stop it. take the prescription, see how you feel, report back to your hopefully, listening practitioner and say, gosh, for some reason I didn't do well with NDT. Maybe I want to try a T4, T3 separately and have to play with it a little bit, because everybody's going to be different. There is no true maximum, but true maximum I'm talking about for the whole world. But, I've had patients with just, heck, was a lady with like 2.5 micrograms of T3, just threw it through the roof. Okay.
Hey,
and so,
I noticed that difference even in 2.5 micrograms.
right.
That's just
And
personally me. I can, yeah.
so whereas I really can have somebody take 25 and barely notice it.
Yep.
Okay.
Absolutely.
And so please everybody hear that. I have people who can take 2.5 micrograms and it's like I lit them on fire. It's like, oops, sorry about that. It goes away, I promise. And so
Yeah.
and then 25 and they go like, well, Echo, that's a lot. What is your heart rate? And here's the beauty. We're all wear devices that we can monitor our heart rate. You go
That's
like,
right.
it's just
The
ticking along.
diagnostics are there. Like it was
Yeah.
like the doctor that told me she thought I was hyper because I talked fast. I was like, yeah, girl, I'm from downtown Chicago, been talking fast my whole life.
This is
That's
East
not a
Coast stuff.
diagnostic.
Exactly. You're just too California. Come on, stop it. Sorry, go on. Yeah.
Okay, I don't want to
Right.
keep you too long. I have one more
No.
question for you. But everyone, just so you know, look, hyperthyroidism in Graves seems to be on the rise. And what I did is Gary and I, Dr. Foresman and I recorded he's wonderful at describing hyperthyroidism in Graves. So I took that audio, and if you go to lruss.com/Graves, that's where you send everyone or yourself if you're struggling with hyperthyroidism or Graves. So I just want to throw that out. I'm getting lots of questions about it. And I've had some friends come to me who've had that issue recently. So just everyone, there's a free resource right there, lruss.com/Graves, 40-minute audio with Dr. Forsman talking about it. So the one question I want to ask you,
And just everybody, just a little blurb about that. I have patients who have both Graves antibodies and Hashimoto's antibodies.
That's right.
Yes, it does exist. And how do you know? Because you frickin' test for it.
That's right. Yeah, you talk about that in our audio.
It just bothers me so much. I'm like, that can't exist. I'm like, well, measure it and you'll see that it does, and you guys, the people out there, I'm sorry for you because you kind of like slash somewhere between Graves and Hashimoto's. You guys are tough to treat. Okay.
Yeah, it's a tough one.
So that does actually give us next level difficulty. So it does exist. Okay. So, but Graves is treatable and it can go away. It can be related to all the things that can cause autoimmunity, which is its own discussion, of course.
That's right. And we have that discussion. We have a 40-minute discussion. That's why I'm letting everyone know. lruss.com/Graves if you need to hear that, because, wow, you really do a great number at breaking that down, including the being positive for both.
Okay, good.
And how that can present itself. Yeah. Okay, one last question. And not like we're trying to sell a product, but talk to me about Satiate. Everyone, by the way, you can go to middlepathmedicine.com. Gary has great articles on there about so many different ailments. And also, I recommend his acute viral protocol for this winter and this flu season. Every time I have done that, I have nipped it or shortened my experience of the cold or whatever it is. So go check out his acute viral protocol for, kids are back in school now and everyone's going to be getting something. Okay, tell us a little bit about Satiate.
But just a quick thing, like we were saying about there's no limit. The acute viral protocol, one of the components is using, vitamin D, 50,000 units 3 times a day for 3 days. By the way, COVID people, I would actually continue it for 5 to 7 days. I've just found for people with COVID, it works better if you take it a little bit longer. And I've never had a complication. However, if you do measure a vitamin D, like a week later, it'll be close to 200, and of course, your doctor will freak out. So
don't get tested for vitamin D right after.
Vitamin D right afterwards. It will freak your doctor out. Remember, like we said, don't take your thyroid.
And I've done it many times. I get 50,000 IU pills, and I do that when
they come in 50,000s, etc. So it's funny way bringing up the satiate has to do with controlling blood sugars, and so people who have, I like using continuous glucose monitors for anybody, especially in the prediabetes crowd. Anybody who doesn't have prediabetes can get good information as well. And so, and measuring your blood sugar swings can affect you so much and make you feel like you're hyper and hypothyroid, and you really have blood sugar swing issues before you've even gone on to develop anything like prediabetes and things like this. And so one of the best things is to say, wow, my blood sugar swings when I eat this or I don't eat this, and be very clear. The first data point is to look, well, maybe I shouldn't eat that. So,
Right.
you know,
And maybe I
you
should
want a
test it.
blood sugar swing of like whatever your pre-meal blood sugar is, and you want whatever you eat to maybe cause up to a 40-point swing in blood sugar. Okay, that's it. So if you're sitting at 100, it shouldn't go higher than 140. You can do the rest of the math. And if you do anything more than that, you got to think about, maybe I shouldn't be doing that. Or the another thing that I would tell you that can be useful is take this. The satiate is just, it's called mesoporous silica. It's a way of binding to enzymes and slowing the absorption, not eliminating the absorption, slowing the absorption, especially of carbohydrates as they go through the intestinal tract, so that you get a much easier, smoother flow of your blood sugar. And it takes away so many of the symptoms related to hyper and hypoglycemia. And at the same time, you can help with digestive difficulties and things like that. And it's such and it's non-systemic. It is a form of silica-based. It binds to the enzymes and releases them slowly. So it doesn't get absorbed into your body. So the risk of systemic side effects are almost nil when you take something like this. It can dramatically affect and improve your blood sugar. It can make you feel, it's called satiate for a reason. You can make you feel fuller for longer, which is a good thing.
Because then you won't make maybe some culinary mistakes.
So exactly. So you feel you have, control of blood sugar swings. You feel better. You have less gas, less bloating, some other types of things, and it's non-systemic. So it's really kind of a breakthrough in terms of something that's available. Take 2 caps twice a day before your 2 biggest meals, and even within our own family, using the satiate, the changes, how much it prevents blood sugar swings when you eat maybe some of the not so right things is just amazing. So it's kind of helpful. It's not trying to get you to eat the wrong things, but it's trying to help
it's a
you,
nice
especially.
hack.
It's a nice hack, exactly. So it's a good thing, and it makes a difference because some of the people who thought, they had that they're having tachycardia related to T3, it really was some hyperglycemia issues.
That's right.
And it was tough for them to tell because a few hours later, and they had gone an hour between their morning thyroid, and they started to eat, and they were having blood sugar spikes, and they didn't realize once again until you tested it. And so
that's right, because they're like, "Oh my gosh, my heart's pounding," and you're like, "Right, well,
and
where's
it's
your
not
blood
the
sugar?"
T3, and then you look, where's your blood sugar, and it's actually their blood sugar, and you can test that. Continuous glucose monitors, by the way, for everybody, are available over the counter. I use the one called Stilo from Dexcom because Dexcom's a really good company. There's several others. I have I don't have any stock in any of
I
those.
use one. I forget the name,
And so,
Nutrisensia or something.
and I use it on occasion. It's not something you have to do all the time. And by the way, everybody, my A1Cs, I'm just lucky, has always been kind of perfect. But it gives me information about using a continuous glucose monitor about the foods I eat and things and how they affect me. And that would be true for anybody. And so, and these super sensitive people, man, and I'm not one of them. It's amazing how much like you get affected by things like this, and correcting that can make a great difference in your overall endocrine system. Because as I think you pointed out so many times, Elle, what is actually, perimenopausal symptom? What is a thyroid symptom? What is an adrenal symptom? These things overlap so much.
Yep.
And we have to be careful about the one explanation fits all. It's all hypothyroidism, or it's all adrenal, or it's all perimenopause,
Absolutely.
And so but using something like this to the satiate to help with, blood sugar regulation is kind of a breakthrough because it's really good, so.
That's amazing. Well, everyone, you can go find that at middlepathmedicine.com in his supplement shop if you're interested and feeling like you might have some blood sugar issues.
Mm-hmm.
Dr. Foresman, I can't thank you enough. You are always so gracious to come on and explain everything. And also, everyone, if you haven't and you need to jump in and learn about all of this, take the Ultimate Thyroid course. There's 4 hours with Dr. Foresman. I mean, gut health, detox, you name it. Really the most comprehensive thyroid education. And, I know you would agree with me. The more you empower yourself, look, doctors can come and go. The more you know about what ails you, the better you're equipped to help your doctor help you. So yeah.
Yes, you're your own best physician, and some of that is through the education. But remember, whatever we learn, you have to apply it to yourself, and that's by living it. Okay,
That's right.
So it's like you don't know if you like surfing until you surf. It's not just about reading about it. Okay, you got to live this stuff. Okay,
Yeah.
And so when it comes to your thyroid, and that's why you explain it to your doctor. But yes, you're the one who's best able to figure out the right dosages, and it can fluctuate. Okay, so
Yes, it's fluctuated for me over time. You have to pay
Elle is
attention.
a great example of that. And so just that's
So you
because she's
make sure
listening
you
to her
have
own
your
body.
temperature nearby you. You make sure you've got a continuous
Do
heart rate monitor, because when things feel off, you got to go to the diagnostics that you can do at
right.
home and then go test to confirm that,
And I
because
sometimes
temps will
forget
do
to,
it.
can I just throw that in? The
Yeah.
basal temperature is a great useful test. I actually prefer oral temperatures using the ovulation based ones. They're just the oral thermometers. I just think
Yep.
oral testing is better than axillary testing. I know with all respect to the Barneses and the other doctors of the world who've recommended axillary temperatures, they're just not that reliable. And you can
Right,
get
like under
good,
the armpit or right.
exactly. So
Mhm.
the oral temperatures, you can get a simple one, wherever you get them. But oral, forgetting the breast, you can get them for 10 or $15, long and short of it. And just keep it bedside. Basal temperatures in the morning are a great, you go, what? Something's going on. And you notice all of a sudden your basal temperature, which was running, 98 in the morning, is now running, 97. And you go, wow, what is going on here? Do several readings, of course, by the way. Don't
That's
just
right.
base your everything on one reading. But basal temperature is something we've forgotten about. And it's the in vivo, meaning in life corollary. So, gosh, I wonder how, and this is primarily affected by thyroid. Of course, it's more complex than that. But that basal temperature thing, you think something is going on, you go, nah, it couldn't be. Do basal temperatures, okay? That's another
It's
thing
how
that
it's how I found out many, many years ago that I was on too much T3. It's
see,
how I found out I was also hypothyroid back then,
right,
and how I used it when I used NDT to get optimized. I mean, it is amazing. I always have
right.
and I have an example. Like last night, it was a little hot and humid here, and I was a little high. I just got out of the shower, but I felt hot, and I was like, "Is this menopause? I don't know what's going on." So I just took my temp real quick, and just to confirm, and I was like, "Oh no, it's something else or whatever, hormones, or it's hot outside." But like, there's a diagnostic right there, and also heart rate, right? So I mean, there's like so many, yeah.
And remember, the
Take the
menstruating
temps.
women, you guys fluctuate during the month and things like that. So
That's right.
if you're trying to do just a basal temperature that primarily is
Before
affected by
ovulation.
thyroid, do it the first several days of your cycle. And so guys of course can do it anytime, but because guys are easier to treat, just always the way it is. And so
Yeah.
sorry,
Yeah. You
but
are. Yeah. No, it's true.
it's just kind of true. And so but because there's fewer hormones fluctuating, it's just the truth of it. It does, and that's why I think everybody, when we talk about using the different T4s and T3s, your doctor, it's just more difficult sometimes. And that's the push away from that is just because it is a little bit more difficult to use these things. But using things like basal temperature is easy, and it gives you another marker to use. Okay. The heart rate monitors, you can tell if you're taking too much of something. You can tell if you're not taking enough of it,
Hmm.
just for some basic things like basal temperatures, heart rate, and of course how you feel matters. But
Yeah.
but
Absolutely.
become your own best physician because of your in vivo, your in life experience, more so than just what you read.
Yeah. Thank you so much for your time. This is really juicy and just packed. I'm going to actually post this to the NDT page on my website as well. And then, of course, it'll be available to share through Apple Podcasts and Spotify. So thank you so much. And everyone visit middlepathmedicine.com to learn more about Dr. Gary Foresman. And if you need telemedicine in the USA, they do that with his PA, Abby, who is trained under Foresman. So she's got the right person to go to in case she ever had a question.
She's the right stuff. And again, been changing my practice, so I'm trying to be more of a coach. Hey, you could relate to that, as more of a coach than the player. So I'm spending more time doing the research, coming up with the protocols, things like that, than I am in terms of seeing people as much as I used to. But Abby is great, and almost everybody agrees. But I can't see Dr. Forsman, and I go, well, that's a positive. You get to see Abby.
That's great. Well, thank you so much. And for everyone else, we'll see you next time.
Hey, thanks for listening. If you enjoyed this show, I would so appreciate you leaving a review on Apple or Spotify or wherever you get your podcasts. And to learn more about partner discounts on amazing products, visit elleruss.com/discounts.